All right, so welcome to our lecture on STI prophylaxis. Some new changes, some of the new things that have come through, and I want to make sure that we are capturing it. You guys know it, so it helps you with your QE1 exam, it helps you with your NAC OSCE exam, and so forth. So you are not struggling with it at all. Good. So this is a lecture on STI prophylaxis. All right, I have already introduced myself. Let's start with a question. 25-year-old female with no other risk factors comes to your office after a random sexual encounter. What prophylaxis will you provide her, right? So this person has no other risk factors, right? And has just had a random sexual encounter, right? What are you going to give her as a prophylaxis? So over here, the question is asking, right? Over here, the question is asking, what is the most likely STI that you will provide prophylaxis to, right? So HIV, Hep B, Hep C, chlamydia, trichomonas, all of those things, right? So can we provide prophylaxis for HIV? Yes, we can, right? Can we provide prophylaxis for chlamydia? Yes, we can, right? But based on the question, right? Based on the question, what do you think is something that we should provide prophylaxis for sure? What is something that we need to make sure that, you know what, I need to provide this right now? What do you think? Is it HIV or chlamydia? HIV, chlamydia, which one? Okay, it looks like it is chlamydia. Absolutely, absolutely, right? Now, if this person had risk factors, right? If this person had certain risk factors, like multiple sexual partners, right? Or other partner who was, let's say, HIV positive, right? If all of those things were there, then 100%. We need to provide post-exposure prophylaxis for HIV as well. But given that none of those things are mentioned, the most likely easiest lowest hanging fruit to deal with over here is D, chlamydia. Good. Let's move to next. Okay, so I guess most of you guys know the answer. Perfect. Very good, guys. 35-year-old homosexual male comes to your office after a random sexual encounter. He practices receptive anal intercourse and is not regular with barrier methods. What prophylaxis will you advise to him? Right? So over here, we can see a lot of risk factors, right? So first, males who have sex with males, right? So that is something which is a risk factor over here, right? So that is one big thing that we are going to identify, right? Next, we have a person who has random sexual encounter, right? So that is another one, that it's not with like their lifelong partner or anything like that. So that's another risk factor. What else? What else is the risk factor over here, everyone? Can you help me find some of the risk factors? So we have homosexuality or males who have sex with males. That's one. Very good, very good. So anal intercourse is another risk factor. Anything else? Anything else? Very good. No barrier methods, right? No barrier methods is another one. Nice, nice. Anything else you can think of? Age, sure, sure. Age as well, right? Age, male. Okay, good, 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 very good. Absolutely. What else? Random, sure. Anything else? Anything else? Okay, so very good, Dr. Dara, Dr. Simranjeet. So, in important thing over here is, are the people who have receptive sex, are they at more risk, or the person who is giving, right? Is it the person receiving, or is it the person giving? Who is at more risk? Receptive or the other person? Who? Very good, very good. It is receptive, right? Higher surface area, what else? More chances of any sort of trauma, all of those things. So receptive is a higher risk than the person who is the initiator or the person who is on the other end of it, right? So if you look at it, this question is full of risk factors, right? Full of risk factors. So what does this patient need? This patient needs prophylaxis. Prophylaxis against what? Prophylaxis against HIV for sure, right? So HIV post-exposure prophylaxis is indicated for this person, right? Okay, so now let's go through some of the key things what we should focus, pay attention to when we have questions similar to this, right? So anytime they ask you questions in QE1 or even NAC OSCE or any sort of exams, they usually present a case to you, right? 25-year-old female comes to you with vaginal discharge. 28-year-old male comes to you because he has bleeding after anal intercourse and so forth, right? Or 32-year-old male comes to you because he has penile discharge and so forth. So anytime the exams, they will give you a case, all right? For you, the most important thing is to identify what is going on here, right? And by that, I mean, what sort of risk factors is this person having, right? So to identify, to understand the risk factors, we have few things that are important. Number one is our sexual history, right? Number one is our sexual history. What else is important apart from sexual history, everybody? Sexual history is very important. What is another thing that is very important when analyzing these types of questions or cases? What else? See, I like this interactive stuff. So then it also pushes your mind to think about it, right? So number of partners and everything is in sexual history. It comes within sexual history, right? We need to know, apart from sexual history, what else is important when we analyze these sorts of cases. Yeah, that's also sexual history, right, Dr. Binayak? Type of sex and gender as well comes with the sexual history. Other STDs is also part of sexual history. So apart from sexual history, everybody, apart from the whole sexual history, what else will we consider? Apart from sexual history, what else will we consider over here? Okay, sure. What sort of risk factors? Very good, Dr. Kim Kim. Vaccination, right? Vaccination. Okay. What else are we going to consider over here? Whether the person is vaccinated against Hep B, etc. Right? Very good. What else? Dr. Freddy, STIs are more involved in the sexual history. So I'm talking about anything that is apart from sexual history. Partner history is a part of sexual history too. Number of partners, any STI testing in partners, all of those things. Okay, very good. So, history of IV drug use, amazing, amazing, right? History of IV drug use is another big one. Good, very good. What else is important, right? What else is important? IV drug use, super important because that worsens things, right? Anything else? See, this is what QE1 and NACOSKI tests, right? This is what QE1 and NACOSKI tests. What they are testing is they're not testing how deep your knowledge is, right? They're testing how broad your knowledge is, right? They test how broad your knowledge is. So let me help you guys, okay? So key thing is very good, Dr. Simranjit. Key thing is we have to understand the immune status of the person who you're talking with, right? Immune status of the person who you're talking with. So let's say this person comes and says, I have uncontrolled diabetes. Okay. Uncontrolled diabetes, right? Your 35-year-old male with uncontrolled type 1 diabetes who is sexually active with other males. Are they at higher risk of acquiring STIs, HIV, all of that compared to a person without diabetes, healthy, and stuff like that? Yes, no, yes, no? The answer, yes, absolutely. A person who, let's say, is already HIV positive, are they at higher risk for getting other STIs? Absolutely. They are at higher risk of other STIs, right? So these are the key things over here that you have to understand when looking at it, right? A 32-year-old male with type 1 diabetes, right? So that complicates it. What else is another complicating factor? Social determinants of health, right? A 52-year-old homeless male with COPD and diabetes, right? Comes to you with penile discharge, right? So now, is this situation even worse? Like homelessness, bad COPD, uncontrolled diabetes, penile discharge. Does this person need like a full STI checkup? Does this person need like full prophylaxis? The answer, absolutely. Absolutely. So you see, guys, this is how there are differences in treating people who present with just something, right? Like a 25-year-old female, healthy, who works at, let's say, TTC or something, right? Who has a good, stable job, good benefits, all of it, right? Went to a work party and had a random sexual encounter. Okay, sure. This person has fully immune status is good, all of those things. What you will do, you will check her STI profile, you will send her for all the testing and stuff like that. Low risk for anything else. You will give her prophylaxis of chlamydia, gonorrhea, etc., and you will send her home. Right? On the other hand, you have this guy, 52-year-old homeless, COPD, diabetes, etc., comes and says, I had a random sexual encounter last night. Okay, I'm going to check Hep B for sure. I'm going to check Hep C for sure. I will probably initiate HIV post-exposure prophylaxis, depending on what type of sexual encounter this person had, right? So all of these things are very important, right? All of these things are very important. And in Canada, there not only is treatment important, what is important is prevention, right? Not only is treatment important, what is important is prevention. So in prevention, we have two types of prophylaxis, right? What are the two types of prophylaxis, everybody? Two types of prophylaxis. What are the two types of prophylaxis? One is two types of prophylaxis. One is very good, very good. One is pre-exposure, right? One is pre-exposure, and the next one is post-exposure, right? Pre-exposure and post-exposure, right? Now, a lot of these prophylaxis are built in to reduce the potential sequelae of things, right? To reduce the potential complications and those sorts of things, right? If we treat something beforehand, then we don't have to deal with it afterwards, right? So today we are going to talk a little bit about pre-exposure prophylaxis, and we will explore it a little bit more. So sexual history, let me go through it a little bit, right? Partners, so how many partners have you had? Male, female, both, right? Gender of the partners, very important. That keeps adding to the risk. Practices, so types of sex involved, right? So oral, anal, vaginal, those types of sex involved, right? So is there a risk of HIV transmission with oral intercourse or oral sex? Somebody said I had a random oral encounter, right? Male with male, male who has sex with male. They had just oral intercourse. Will you give them HIV post-exposure prophylaxis? Male with male, just oral intercourse. Will you give them HIV post-exposure prophylaxis? Yes, no, yes, no. No, right? Because the risk of transmission with oral intercourse is extremely minimal, right? Extremely minimal, almost no, right? Almost no. So usually with oral intercourse, there's not too much going on, right? Now, what can increase the risk of oral intercourse are few things, right? Can you guys tell me? Like, let's say there are two people who are involved in oral intercourse, right? When will be the risk of transmission more? Very good, very good. So if a person has oral lesions like ulcers, and there is blood or bleeding in somebody's mouth, right? There is blood or bleeding in somebody's mouth, right? So that is very important for transmission of it, right? Or they have a lesion on whatever their external genitalia. That's also another one that can increase the risk for oral. But otherwise, majority of the times, oral intercourse is not a bigger transmitter. Good. Perfect. So that's your types of practices. Good so far, everyone? Understanding? Yes, no, yes, no? All right. Awesome. Perfect. Then we talk about protection, right? You talk about protection. So STI prevention, like pre-exposure prophylaxis, right? Have they taken any vaccine like hepatitis B, hepatitis A, right? Human papilloma virus. This is Gardasil, which you guys might have known, right? So these are very important to know. Have they had any of these things done or not, right? These are the protective measures, right? Are they using any barrier methods of contraception like condoms and stuff? Are they using it every single time, right? So that's very important to know, okay? Then we talk a little bit about the past history. Like I said, right? Past history. Past history is very important in this case, right? So, have they had any previous diagnosis of STI? So, people like males who have sex with males, if one of them has been diagnosed with syphilis or treated with syphilis, the chance of that person having HIV increases a lot, right? The chance of that person having HIV increases a lot, right? So very important. Any partners that are treated for STI and stuff? Again, super important. Good. All right. Now, a lot of guidelines are moving towards fringe groups or vulnerable groups. What do I mean by that? Let me give you an example. All right. So we are going to start with lipid guidelines or cholesterol guidelines. A long time, like 10, 20 years ago, we used to give cholesterol guidelines, which were primarily for adults, and that's it, right? Now, a lot of these guidelines, they are trying to make it tailored to populations, like lipid guidelines, diabetes guidelines, right? So we have lipid guidelines for adults. Do we have lipid guidelines for pregnant females? Have they added an extra paragraph for pregnancy? Yes, no, yes, no. Everyone, Canadian Cardiovascular Society, have they added an extra paragraph of recommendations for pregnancy now? Yes. They have added an extra paragraph for pregnancy, right? So lipid guidelines we have for these guys. We have it for adults as well. Do we have stuff for children as well? Pediatrics? Yeah. Childhood obesity, familial hyperlipidemia. Yes, we have it for kids too nowadays, right? At what age should we start screening with familial hyperlipidemia? At what age should we start statins with hyperlipidemia? Yeah, now we have for children as well. Wow. So, what has been happening now is a lot of these guideline groups are targeting these vulnerable people, are targeting these people at the outskirts of normal population, right? Previously, you're like, oh, yeah, yeah, you take your statin, you're good. Now it's moving further. Same with a lot of things like depression, right? Major depressive disorder. It's like, okay, you can take your sertraline. Fine. What if I'm pregnant? Can I take it? Yeah. What if I'm lactating? Can I take it? Yeah. Okay. What if it's a pediatric person? Will they take it? Maybe switch to fluoxetine. That has higher evidence, right? That, oh, I didn't know that. What if like this person is homeless or something? Oh, then maybe give them like long acting preparations and stuff, right? If they have schizophrenia and things, give them a Abilify or something, an injection. What about contraception? Maybe give them like progesterone injection, right? Depo-Provera lasts for 3 months. You don't have to worry about it. Right? So see, like a lot of guidelines are now moving towards identifying and addressing these populations as well, right? And same exact concept applies over here with sexually transmitted infections, right? So history of pregnancy, very important, right? Are you pregnant? What type of contraception you are using, right? Termination of pregnancy parts, super important over here. So that's another thing that you have to keep it in mind. Good. All right. Now let's talk a little bit about prophylaxis component of it, right? So our STIs, normally we have these STIs, right? Chlamydia, gonorrhea, trichomonas, syphilis, HIV, Hep B, Hep C. Everyone agrees? Is there anything that they would like to add? Hep B, Hep C are more blood-borne diseases, but they can also be transmitted sexually, right? So when you talk about STIs, they are not like at the top of the list. It's like, what STI will you screen for? Hepatitis B. Well, sure, it is sexually transmitted, right? But it is not like the notorious STI, right? They said, what STI will you screen for? Like, I'll do chlamydia, I'll do gonorrhea, right? Something like that. Good. Okay. So this is the list of STIs we have, right? In which cases can we provide pre-exposure prophylaxis? What diseases out of these we provide pre-exposure prophylaxis? Very good. HIV, absolutely. There's pre-exposure prophylaxis for HIV. Gonorrhea, very good. We can provide for gonorrhea as well. Anything else? Pre-exposure. We're talking about pre-exposure, okay? Hepatitis B, pre-exposure prophylaxis, okay? No, okay, no. We don't give usually pre-exposure prophylaxis for hepatitis B. Why? Because 80% of infections with hepatitis B clear by themselves, right? Clear by themselves. So normally we don't. Okay. Right. Anyone else? Anything else we can give pre-exposure prophylaxis to? So this is a point of controversy. Okay. But we provide pre-exposure prophylaxis usually combined for chlamydia gonorrhea, right? Combined for chlamydia gonorrhea. Okay. Combined for chlamydia gonorrhea, right? So what is the medication that we give them? Doxycycline. Doxycycline is something that we can, doxycycline is something we can give them for this. There was an article recently published in CMAJ. I will share it. We'll share the link to that article. You can read it. Doxycycline helps. Doxycycline is primarily active against chlamydia, okay? Not as much against gonorrhea, but it is still used as a pre-exposure prophylaxis. For gonorrhea, you need stronger antibiotics like ceftriaxone and stuff, right? But doxycycline, you can consider it, all right? For HIV, we have pre-exposure prophylaxis. We know it. What is the pre-exposure prophylaxis for HIV, everyone? Same three drugs. What three drugs? There are two medications that are for pre-exposure prophylaxis of HIV. Very good. Truvada. Very good. Truvada. Good. So, dolutegravir plus Truvada, usually we give it as post-exposure, right? Usually we give it as post-exposure. Pre-exposure usually is one pill, right? Truvada, and that is your tenofovir, disoproxil fumarate, right? TDF. What else is there? Plus tenofovir and any other. This is like QE1 stuff. Very good. Emtricitabine. Emtricitabine, right? These are two medications we give for pre-exposure prophylaxis. Good. Perfect. What about post-exposure prophylaxis? Now let's switch gears. Let's move to post-exposure prophylaxis. So, do we have post-exposure prophylaxis for chlamydia? Yes, no, yes, no. Everybody? Do we have post-exposure? Yes, we do. Perfect. Do we have post-exposure prophylaxis for gonorrhea? Yes, no, yes, no. Yes. Do we have post-exposure prophylaxis for trichomonas? Yes, no, yes, no. Okay. Everybody says yes. Okay. Post-exposure prophylaxis. All right. Do we have post-exposure prophylaxis for syphilis? Yes, no, yes, no. HIV, we have it. That everybody knows. Hep B, Hep C, we have it for Hep B, Hep C. Yes, no, yes, no. Oh my God. Everybody's saying yes for everything? Okay, let me ask this then. All right. What is the medication for post-exposure prophylaxis against chlamydia? And I'm not talking about treatment. I'm talking about prophylaxis. Okay. I'm not talking about treatment. I'm talking about prophylaxis. Tell me about medication against chlamydia. Okay, you azithromycin or doxycycline. Perfect. Great. What about gonorrhea? What about gonorrhea? So is ceftriaxone prophylaxis or treatment? Treatment. Okay, so then do we have prophylaxis or no? Exactly. Okay, Dr. Arasi. Okay, so what's the prophylaxis against gonorrhea? Doxy is pre-exposure prophylaxis. Doxy is post-exposure prophylaxis as well. Okay, so we will give a query over here. We will leave it as a query. Dr. Aruj is going to look it up and let us know. Post it in my group on Telegram and let me know what is the post-exposure prophylaxis for gonorrhea. Okay. We give doxycycline as a pre-exposure for sure. Post-exposure prophylaxis, you let me know. Ceftriaxone is the treatment of it. Good. Perfect. Trichomonas. Do we have post-exposure prophylaxis for trichomonas? Yes, no, yes, no. Okay, what is a post-exposure prophylaxis for trichomonas? What is a post-exposure prophylaxis for trichomonas? Is that prophylaxis? Is metronidazole prophylaxis or treatment? Okay, so it's treatment. So do we have prophylaxis against trichomonas? Yes, no, yes, no? No. Okay, perfect. All right. What about syphilis? Do we have post-exposure prophylaxis? People like, I better say no. I don't know. Penicillin, right? Penicillin. So penicillin is something that you can consider, right? For treatment as well, you can consider penicillin too. Okay. We don't have anything specific that we give for prophylaxis though, but you can consider if it is a high risk case. HIV, what is a post-exposure prophylaxis of HIV? What is a post-exposure prophylaxis of HIV? Very good, very good. It is your previous medications, right? So you can give tenofovir, you can give lamivudine, right? And you can give dolutegravir, right? Or you can give Truvada plus dolutegravir as well. All of this for 28 days and you're good. Awesome. For hepatitis B and hepatitis C, do we have post-exposure prophylaxis for hepatitis B and hepatitis C? Yes, no, yes, no? Nope, we don't, right? We don't. Perfect. So let's pause over here.